Stomach and duodenum. The function of the stomach is to act as a 1. Reservoir for ingested food. 2. Break down foodstuffs mechanically. 3. Digestion of food before pass to the duodenum. Blood supply. The stomach has an arterial supply on both lesser and greater curves. On the lesser curve, the left gastric artery and right gastric artery. The right gastroepiploic artery runs along the greater curvature of the stomach, eventually forming an anastomosis with the left gastroepiploic artery. The fundus of the stomach is supplied by the vasa brevia or short gastric arteries. Veins. In general, the veins are equivalent to the arteries. Nerves of gall plexus around the oesophagus condenses into bundles that pass through the oesophageal hiatus. Gall fibers are both afferent, sensory, and efferent. The efferent fibers are involved in the 1. Receptive relaxation of the stomach. 2. Stimulation of gastric motility. 3. Secretory function. The anatomy of the anterior and posterior vagus nerves in relation to the stomach. Gastric mucus and the gastric mucosal barrier. The gastric mucus layer is essential to the integrity of the gastric mucosa. It is a viscid layer of mucopolysaccharides produced by the mucus-producing cells of the stomach and the pyloric glands. Many factors can lead to the breakdown of this gastric mucus barrier. 1. Bile. 2. Non-steroidal anti-inflammatory drugs, NSAIDs. 3. Alcohol. 4. Trauma. 5. Shock. Investigation of the stomach and duodenum. Flexible endoscopy is the gold standard investigation of the upper gastrointestinal tract. 1. Taking biopsies. 2. Performing interventional techniques. 3. Facilitates teaching and training. Axial imaging, particularly multislice Connecticut, is useful in the staging of gastric cancer. Cord PET is useful in staging gastric cancer. Endoscopic ultrasound is the most sensitive technique in the evaluation of the T stage of gastric cancer and in the assessment of duodenal tumors. Laparoscopy is very sensitive in detecting peritoneal metastases, and laparoscopic ultrasound provides an accurate evaluation of lymph node and liver metastasis. Connecticut positron emission tomography. Helicobacter pylori. Importance in the etiology of a number of common gastroduodenal diseases as 1. Chronic gastritis. 2. Peptic ulceration. 3. Gastric cancer. H. pylori leads to the disruption of the gastric mucus barrier by the enzymes produced by the organism. And the inflammation induced in the gastric epithelium is the basis of many of the associated disease processes. The association of the organism with chronic, type B, gastritis. Gastritis affecting the body, common in the developing world, may lead to hypochlorhydria and gastric neoplasia. Helicobacter infection is amenable to treatment with antibiotics. Commonly used eradication regimes include a proton pump inhibitor and 2 antibiotics, such as metronidazole and amoxicillin. Gastritis. The spiral bacterium H. pylori is critical in the development of type B gastritis, peptic ulceration and gastric cancer. Eradication, recommended specifically in patients with peptic ulcer disease, can be achieved in up to 90% of patients with a combination of a proton pump inhibitor and antibiotics. And reinfection is uncommon, less than 0.5%. Erosive gastritis is usually related to the use of NSAIDs. Type A gastritis is an autoimmune process and is associated with the development of pernicious anemia and gastric cancer. Reflux gastritis. This is caused by enterogastric reflux and is particularly common after gastric surgery. Erosive gastritis. This is caused by agents that disturb the gastric mucosal barrier. NSAIDs and alcohol are common causes. Stress gastritis. This is a common sequel of serious illness or injury and is characterized by a reduction in the blood supply to superficial mucosa of the stomach. Peptic ulcer. Most peptic ulcers are caused by H. pylori or NSAIDs. Duodenal ulcers are more common than gastric ulcers, but the symptoms are indistinguishable. Gastric ulcers may become malignant, and an ulcerated gastric cancer may mimic a benign ulcer. Gastric antisecretory agents and H. pylori eradication therapy are the mainstay of treatment, and elective surgery is very rarely performed. The long-term complications of peptic ulcer surgery may be difficult to treat. The common complications of peptic ulcers are perforation, bleeding and stenosis. The treatment of the perforated peptic ulcer is primarily surgical, although some patients may be managed conservatively. Common sites for peptic ulcers are the first part of the duodenum and the lesser curve of the stomach, but they also occur on the stoma following gastric surgery. Infection with H. pylori and the consumption of NSAIDs are the most important factors in the development of peptic ulceration. Cigarette smoking predisposes to peptic ulceration and increases the relapse rate after treatment. Duodenal ulceration incidence. Even before the introduction of H2 receptor antagonists, the incidence of duodenal ulceration and the frequency of elective surgery for the condition were falling. This due to the widespread use of gastric antisecretory agents and H. pylori eradication therapy for patients with dyspepsia. The peak incidence is now in a much older age group and more common in men. Duodenal ulcer shown by barium meal. Gastric ulcers incidences with duodenal ulceration, H. pylori and NSAIDs are the important etiological factors. Gastric ulceration is also associated with smoking. Other factors are of lesser importance. Gastric ulceration is less common than duodenal ulceration. The sex incidence is equal and occur in older population. Malignancy in gastric ulcers. Chronic duodenal ulcers are not associated with malignancy and, in contrast, gastric ulcers are. It is fundamental that any gastric ulcer should be regarded as being malignant. Multiple biopsies should always be taken. Clinical features of peptic ulcers. Pain. The pain is epigastric, often described as gnawing, and may radiate to the back. Eating may sometimes relieve the discomfort. The pain is normally intermittent rather than intractable. Periodicity. One of the classic features of untreated peptic ulceration is periodicity. Symptoms may disappear for weeks or months to return again. This periodicity may be related to the spontaneous healing of the ulcer. Vomiting. While this occurs, it is not a notable feature unless stenosis has occurred. Alteration in weight loss or, sometimes, weight gain may occur. Patients with gastric ulceration are often underweight, but this may precede the occurrence of the ulcer. Bleeding. All peptic ulcers may bleed. The bleeding may be chronic and presentation with microcytic anemia is not uncommon. All such patients should be investigated with endoscopy. Acute presentation with hematemesis and melena may occur. Investigation of the patient with suspected peptic ulcer. Treatment of peptic ulceration. The vast majority of uncomplicated peptic ulcers are treated medically. Surgical treatment was aimed principally at reducing gastric acid secretion and, in the case of gastric ulceration, removing the diseased mucosa. Medical treatment modifications to the patient's lifestyle, cessation of cigarette smoking, H2 receptor antagonists and proton pump inhibitors. Most duodenal ulcers and gastric ulcers can be healed by a few weeks of treatment. Eradication therapy. Eradication therapy is now routinely given to patients with peptic ulceration, especially if a patient has a peptic ulcer and H. pylori. Ulcers that fail to heal. Peptic ulceration fails to heal in a small minority of patients. The ingestion of NSAID should once again be addressed. A diagnosis of Zollinger-Ellison syndrome. Malignancy need to be ruled out. Surgical treatment of uncomplicated peptic ulceration. The incidence of surgery for uncomplicated peptic ulceration has fallen markedly, now a day used for the complicated ulcer. Operations for duodenal ulceration. Duodenal ulcer surgery. Rationale. Procedures devised for the treatment of duodenal ulcers have the common aim of excluding the damaging effects of acid from the duodenum. 1. Diversion of the acid away from the duodenum. 2. Reducing the secretory potential of the stomach. 3. Or both. All of the operations DVSED achieved their aim to some extent, but with varying degrees of morbidity, mortality and postoperative side effects. Bill Roth 2 gastrectomy. Bill Roth 2. 2/3 of the stomach removed, the duodenal stump is closed and the stomach anastomosed to the jejunum. Bill Roth I gastrectomy. Bill Roth I, the lower half of the stomach is removed and the cut stomach anastomosed to the first part of the duodenum. Truncal vagotomy and drainage. Truncal vagotomy combined with drainage was the mainstay of treatment of duodenal ulceration. Section of the vagus nerves, which are critically involved in the secretion of gastric acid, reduces the maximal acid output by approximately 50%. Because the gall nerves are motor to the stomach, denervation of the antropuloduodenal segment results in gastric stasis. 1. Pyloroplasty, Heineke, Mikulich, is the most popular drainage procedure, longitudinal section of the pyloric ring enclosed transversely. 2. Gastrojejunostomy. This is performed through opening the lesser sac and performing an anastomosis between the most dependent part of the antrum and the first jejunal loop. Truncal vagotomy. Pyroplasty. Gastroenterostomy. The jejunum is anastomosed to the posterior, dependent, wall of the stomach. Highly selective vagotomy. The anterior and posterior vagus nerves are preserved, but all branches to the fundus and body of the stomach are divided. Only the parietal cell mass of the stomach was denervated. Truncal vagotomy and enterectomy. In addition to a truncal vagotomy, the antrum of the stomach is removed, thus removing the source of gastrin, and the gastric remnant is joined to the duodenum. Operations for gastric ulcer. In contrast with duodenal ulcer surgery, when the principal objective was to reduce duodenal acid exposure, in gastric ulceration the diseased tissue is usually removed as well, with advantage that malignancy can then be confidently excluded. Bilrothi gastrectomy. This was the standard operation for gastric ulceration until medical treatments became prevalent. Cycli of peptic ulcer surgery. 1. Recurrent ulceration. 2. Small stomach syndrome. 3. Bilious vomiting. 4. Early and late dumping. 5. Diarrhea. 6. Malignant transformation. Recurrent ulceration. Recurrent ulcers may present with complications, particularly bleeding and perforation. Small stomach syndrome. Early satiety follows most ulcer operations to some degree, including highly selective vagotomy. Bile vomiting. Bile vomiting can occur after any form of vagotomy with drainage or gastrectomy. Eating will precipitate abdominal pain and reflux symptoms. Bile chelating agents can be tried but are usually ineffective. In intractable cases, revisional surgery, enterectomy and Roux-en-Y reconstruction may be the better option. Early dumping. Early dumping consists of abdominal and vasomotor symptoms that are found in about 10% of patients following gastrectomy or vagotomy and drainage. It also affects a small percentage of patients following highly selective vagotomy due to the loss of receptive relaxation of the stomach. The small bowel is filled with foodstuffs from the stomach, which have a high osmotic load, and this leads to the sequestration of fluid from the circulation into the gastrointestinal tract. This can be observed by the rise in the packed cell volume. The principal treatment is dietary manipulation. Small, dry meals are best, and avoiding fluids with a high carbohydrate content also helps. The somatostatin analog octreotide given before meals has been shown to be useful in some individuals. However, this treatment can lead to the development of gallstones, and it does not help the diarrhea from which many patients with dumping also suffer. Revisional surgery may be occasionally required. Features of early and late dumping. Dumping. Early-late incidence 5-10%. 5% relation to meals almost immediate. Second hour after meal. Durations of attack 30-40 minutes. 30-40 minutes. Relief lying down. Food aggravated by more food exercise. Precipitating factor. Food, especially carbohydrate-rich and wet, is early dumping. Major symptoms: epigastric fullness, sweating, lightheadedness, tachycardia, colic, sometimes diarrhea, tremor, faintness, prostration. Late dumping. This is reactive hypoglycemia. The carbohydrate load in the small bowel causes a rise in the plasma glucose, which, in turn, causes insulin levels to rise, causing a secondary hypoglycemia. This can be easily demonstrated by serial measurements of blood glucose in a patient following a test meal. The treatment is essentially the same as for early dumping. Octreotide is very effective in dealing with this problem. Malignant transformation. Gastrectomy or vagotomy and drainage are independent risk factors for the development of gastric cancer. Bile reflux gastritis, Intestinal metaplasia and gastric cancer are linked. Gallstones. The development of gallstones is strongly associated with truncal vagotomy. Following truncal vagotomy, the biliary tree, as well as the stomach, is denervated, leading to stasis and hence stone formation. The complications of peptic ulceration. The common complications of peptic ulcer are perforation, bleeding and stenosis. Perforated peptic ulcer epidemiology. Despite the widespread use of gastric anti-secretory agents and eradication therapy, the incidence of perforated peptic ulcer has changed little. Previously, most patients were middle-aged, with a ratio of 2:1 of male, female. Clinical features: patient may have a history of peptic ulceration, develops sudden onset severe generalized abdominal pain due to the irritant effect of gastric acid on the peritoneum. Bacterial peritonitis supervenes over a few hours, usually accompanied by a deterioration in the patient's condition. Initially, the patient may be shocked with a tachycardia, but apyrexia is not usually observed until some hours after the event. The abdomen exhibits a board-like rigidity and the patient is disinclined to move because of the pain. The abdomen does not move with respiration. Patients with this form of presentation need an operation, without which the patient will deteriorate with aseptic peritonitis. Mr. Hamilton Bailey watching for abdominal movement on respiration. In the case of a classically presenting perforated ulcer, the abdominal movement is restricted or absent. Investigations: an erect plain chest radiograph will reveal free gas under the diaphragm in an excess of 50% of cases with perforated peptic ulcer, but Connecticut imaging is more accurate. All patients should have serum amylase performed, as distinguishing between peptic ulcer, perforation and pancreatitis can be difficult. Measuring the serum amylase, however, may not remove the diagnostic difficulty. It can be elevated following perforation of a peptic ulcer, although, fortunately, the levels are not usually as high as the levels commonly seen in acute pancreatitis. Treatment: the initial priorities are resuscitation and analgesia. Analgesia should not be withheld for fear of removing the signs of an intra-abdominal catastrophe. In fact, adequate analgesia makes the clinical signs more obvious. Following resuscitation, the treatment is principally surgical. Laparotomy is performed. Laparoscopy may be used. Peritoneal toilet to remove all of the fluid and food debris. In duodenal perforation, it can be closed by several well-placed sutures, closing the ulcer in a transverse direction as with a pyloroplasty.